Then we'll go on to the next theme, and it will be retinal detachment cases. One thing that you've noticed, I'm sure, in your practice is an increased incidence of retinal detachments. And when do retinal detachments show up at your practice or your hospital? Late Friday. No, yeah, after months. Okay, yes. So that's already complete. And when is it? At Friday, 3 p.m. Right? Yeah, it's always the same thing. So the big question is also: do I have to treat right away? Can I wait till Monday? This, at least in our place, it's a discussion because the retinal surgeons, they don't seem to like to work on the weekend. I don't know why. I have no idea. I thought that was what the weekend was for, right? No. So no, but do we have any evidence of when to treat? That's a big question. So, first of all, I wasn't completely sure if this is the right way to say it, but because incidence and population growth. Anyway, there's more. Yes, there are more eyes, and more eyes can have retinal detachments. That makes sense. But then we have an aging population. So the longer you're around, the more chances are that your retina can detach. Very simple. If you die with 37, like in the Middle Ages, then you died before you had retinal detachment, or glaucoma, or wet AMD, or anything, cataract. So that's why we have the problem. But then we have, I tend to tell patients when they say, they tell me, Dr. Colvin, don't get old, don't get old. I say, but nobody wants to die young. And so that's my thing, everybody's telling me don't get old, but I'm like, well, that's part of life. So we have increased, probably also in combination with aging population, increased cataract surgery, and we have very high increase of myopia, which I'm sure you notice in your countries too. So, for example, a group in Holland, there's a lot of studies from Asia which are going through the roof. It's like some of the kids they look at are like 95% myopia, and so here we have, this is from good old Europe, and we have here an increase of 44% between 2009 and 16, and this is already a long time ago if you think of it. It's going up a lot faster. What are the reasons for the tablets? Yeah, cell phones? No sunlight? Right, lifestyle right, distance and near work, right? Mm-hmm. It could be too. So, but sometimes it's hard to differentiate pollution, and so people in cities. If you think of the fact, if you grow up in a city where you look out of the window and the next house is there, you don't even have any distance vision, really. Where do you look? Here we look at the mountain and we can see, is there a cross on top or not? If my vision is good, I can see the cross, and I'm like, okay, I'm fine. But if you grow up playing outside 2 and 3 hours a day, which I did as a kid, that was normal. But if you live in a city where there is pollution, but there's also no room, so there's different things, and also the lighting, right? No sunlight, okay. And then you have this competition too. You have kids. I don't want to single out any certain group but there's certain countries where kids go to school from like 6 in the morning till 6 in the afternoon, and then when they come home, they have a tutor that tutors them till 10 at night so that they will be the best of the best of the best. And then while they're not studying, they have their cell phone. So, right, you have all those things. But this is not the theme of my talk, so let's finish that. It's just increased myopia. So what could we do to better treat or better prevent retinal detachment altogether? Preventing myopia. Any ideas on that? Do you have?
They're using new contact lenses at school.
Yeah, ortho K. Atropine, yeah.
Daylight.
Right.
I think that's the only one that is proven that makes the myopia decrease.
That's right. So make sure, kick your kids out of kick them out, out, come back 2 hours later, you can come back. But then it could be that they get a blunt object on their eye, but it's okay. You have to, something's going to happen. Soccer or whatever, that's okay. It's fine, it's part of the risk. The only people don't have any injuries are the people that are in pathology, right? They're already, yeah. So no, you have, and it's interesting. We had the time there was something called Wii-itis when they came out with the Wii, with the Nintendo Wii. I don't know if you remember that thing, and they had problems with their hands, and they had and then they showed the percentage of people kids falling from trees was going down like this, but kids with damage to their bodies because of playing computers was going like this. So it was like they're not falling out of trees because they don't even know how to get on top, climb a tree, but they are having trouble because of computer games. I think I'm getting old, but whatever. So we have preventing myopia, but there is good data about these lenses. There's also spectacles. Hoya and Essilor make them. MyoSmart, I think. And they have good data, actually. But naturally, that's also, I would rather have, if the first step is the normal things to do, normal is a bad word, I know, but the natural things to do, send your kids outside. It's not always possible, if there's different reasons why you can't send your kids out 2 hours a day.
Compensate on the weekends.
That's good, yeah. Spend time with your kids. That's definitely an important thing. Because if the parents are all on their phones, then what are the kids going to do, right? Yeah. So it's something to think about. Good. Then we have perfecting surgical skills. I'm thinking about, naturally, if you have a bunch of complications in cataract surgery and break a bunch of bags, and then you have, or if you don't know how to do YAG laser and you completely destroy the eye, then you're gonna have trouble later, and the retina is not very forgiving in that way. So how can we do that? Practice makes perfect, right? Yeah. Yeah, and I would say also mentorship. We have some situations in some countries where it's like see one, do one, teach one, and then just go, and I only want to hear from you when you have complications. Other countries, they really walk you through every step and are sitting next to you and sweating while you're operating. So it depends. Some people flourish when they're alone and they can do it on their own. Other people are more like, I need to have someone next to me telling me every step. So I'm saying perfecting surgical skills is an important thing, but it's not like every hospital will do the same, every system. Screening. How can we improve screening? Yes, I would say that's something. Why would you say that's a good point? Why is ultra wide field?
Because it's easier for people that are not used to using trained gold on this, or that have the time to do a really good inspection with 20 diopters.
Right. So it's a time thing. It's also, I think sometimes it's just laziness too, because I have to put drops in, I have to wait another 20 minutes and so on. So we don't want to excuse it. If you have some reason to do that, or once a year or something, I think it would be important to do a real thorough examination. But I'm saying, for example, in the future, it might be that even the GP has an Optos and does that. So this takes a picture, and there will be optometricians and opticians and whatever. They will buy these machines, and they will be sending these pictures to someone, and some of us or some of our colleagues might be in doing that on a side job or so, is looking at these and screening. Or AI, everybody talks about AI, and it is definitely being worked on. Okay. Then naturally also treating symptomatic tears. What would you do with asymptomatic round hole that comes up in an exam? Okay.
It is asymptomatic.
It's asymptomatic, yeah. And if it's pigmented anyway, whatever, just don't touch it. Wait, yeah. But you say, where do they live? If you think that they live on the mountain or something?
Access to medical care or
Okay. Okay. Mm-hmm. Mm-hmm. Okay. Mm-hmm. And that has changed over the years. You know, when we started having laser, we thought we got to laser everything because we have this wonderful tool. We say to a hammer, everything looks like a nail, you know, and you have a new hammer and you're like, whoa, everything looks like a nail, you know, I'm going to... And then you realize, wait a minute, you know, we look at eyes, if you look at like cadaver eyes and you see, oh, these people all had all kinds of tears and they all healed, and do we have to really treat them? Not in every case, but definitely symptomatic. And then we have some cases. I'm sorry, but I know everybody likes to watch videos nowadays, but I didn't. You guys just can watch your videos on YouTube, because my problem was, I just apologize. I don't have any videos of the surgeries, but we have here very different presentations. Here, the first patient comes in, hand motion, 2 days ago. So you think of that. He's within 2 days from noticing that something's wrong to macular detached, retinal detachment is with hand motion, right? And here we have the same thing. Oops, sorry. But the progression is still outside of the, or at the edge of the arcades. 20/20 vision. So two very different patients, but how do we treat them? What do we do? Okay, so we'll look at the factors affecting visual recovery after successful repair of macular off retinal detachments, findings in the big study in the UK by Yorston, published last year. Oh no, the year before last, sorry. Factors that came out in 2,074 retinal detachments with visual acuity under 612. The factors that came out were patient age. If patients were over 80, there was a big difference of how good it resolved. Male gender was positive. Preoperative visual acuity. There has to be something good about being a guy, right? No. Preoperative visual acuity, duration of central vision loss, PVR grade, lens status, and if it was total or not total, and ocular comorbidities. So, as I was saying at the beginning, your patient comes in, goes to the general ophthalmologist. I would say start seeing black little dots flying around on Saturday. Ignores it. Sunday, ignores it because it's Sunday. And then on Monday, Tuesday, Wednesday, thinks, something's different, and I'm starting to see this part of my visual field is blurry. It must be a cold. I'm like, what cold makes that? I'm not sure, but it's a cold. I'm sure it's a cold. Then on Thursday, they're like, the wife is like, you gotta go to the hospital. Something's wrong. And on Friday morning, they go to their general ophthalmologist, and then they check them, and then on Friday at 3 o'clock in the afternoon, when you're just ready to get done with your work, this patient shows up, right? That's why we're saying, how long is the central vision loss gonna be if they come in on Friday? So there was a study done in 2021, urgency of retinal detachment repair. Is it time to rethink our priorities? And what came out was that patients, and this is really small, but it's even smaller here. So here we have the decile, which is the 10th part. So 1 day or smaller than 1 day, 1 to 2 days, 2 to 3 days, 3 to 4, 4 to 5, 5 to 6, 6 to 7, 7 to 8. And then it's, 7 to 8. And then it goes 8 to 13, 13 to 28, more than 28. So basically this is more than a month, okay? it's interesting because you have still, I mean, even here, you have percentage of eyes that are still have a visual acuity that is a gain after the operation, right? But so we notice here that the big drop off, if you want to say, is between 1 and 3 days, right? And then it goes down. So basically, macula off regmatous retinal detachment of short duration, and they define smaller than 72 hours, are only marginally worse than outcomes than macula on, which is, on the one side, kind of surprising. You're like, wait a minute, you know? So do I have to really do it on Saturday? So what we do in our hospital is, if there's no change, you know, they notice it's already macula off, then we can do the surgery on Monday. If the macula is on, but while they're in the hospital waiting for surgery, there's another a marked reduction in their vision, then we will schedule the operation for Saturday or Sunday. So that's the way we do it, based also on these studies. So the best visual acuity is with macula on with a superotemporal break. Second best would be macula off within 72 hours, then other, and then macula on, other, and then macula off, other. What reasons could there be for, even if it's a macula on, that is still long, it's been not operated for longer than 72 hours, that it's a worse outcome? What could you imagine? Right. Risk of PVR. Which is the main single reason for surgical failure important on your test? Which, yeah. So, interesting, we come back to case 6. We did PPV with gas in both eyes. And I mean, I have to present some kind of cases where they were operated and they were positive outcomes, because or else you'll be like, what do they do in Salzburg? And they both came out at 2020. So interesting, you wouldn't think that these two patients with the same beginning, with an extremely different beginning, hand motion and 2020, end up at the same spot. That's very encouraging. We have a patient, 60-year-old male, comes in with vision loss since 4 days and hand motion on the left eye. Pseudophakic patient, and the right eye is within normal limits. What examination do you do on the healthy eye? Right. So don't forget. What's the chance? What are the risks of a second eye, a fellow eye, to have retinal detachment compared to the general population? What is the factor of risk? No, I'm factor. It's a number. So to develop retinal detachment or a whole is 1,000 times more common than the normal general population. So you have to tell the patients, that's what every time, because the first time you get one, oh yeah, I had the black dots and the cold that made me see bad, right? You can have that story one time, I say. Next time, if you get some kind of a cold that makes your eye feel strange, then come to the doctor, and if you come one time too many, it doesn't matter. But one time too few, that's the big deal. So you have to think, I always say, don't panic, but also don't ignore the symptoms on the second eye. That's kind of, so one of the reasons we said, well, how can we prevent retinal detachments. One of them is educating especially the people who are at high risk, which is high myopics naturally. We think of that, but we also have to think of the people, especially the people who have had it on one eye. And if it's a factor 1,000, naturally you have to say it's not this is the high incidence in the whole population. So times 1,000 doesn't mean you're going to have your retinal detachment within the next 3 months. I'm not saying that. But we have had our patients within 2 weeks, and it's like, okay, you know. Okay, so we have a bullous retinal detachment, and we have a big tear. Now, we do have to remember that in an ultra-wide field photography, this is sort of like, you know how Alaska is way bigger than it should be in real? It's the same thing with the tears, right? This tear isn't that huge. It's big, but it's not that huge. But it's like Alaska is spread out to be big because we put it on a plane, right? And so sometimes, I don't know how when you do laser, I tell the residents to laser out here somewhere, and I'm like, sometimes I forget that it's really hard to get out there because the technology is crazy how far you can actually take a picture, and then how far you can actually get a good laser on there, or also that it looks like a big area, but it's actually a pretty small area. So it's just something to remember. Okay, so the lady was treated. We use what do you see here? You think that's laser?
No, that's lattice.
No. Laser mostly has more little single spots. Cryo, that's cryo, right? Okay, so we had sometimes we do both, but if it's so this was cryo. Patients got really good, 20/30, perfect, but it's not quite so perfect. The patient has visual disturbances. Something is different. I can't really say what it is, but my eye is like it's not my own. What can you imagine that could be? That's a possibility. It's very common. Right. Right. Mm-hmm. Mm-hmm. So we have some really smart people here. Right. So what do you notice here? It's very, very hard to see. If I didn't know what it is, I would be like, oh, that's just whatever. That's just the artifact or something. So do you notice anything with the, I mean, this on the, it's harder to see it on the big picture, but on the smaller one?
You can see where the vessel, where you can see how.
That's right. So look at the vessels. You can see that the vessels, and then there's as if there was just sort of like a shadow of it, or a second line. And this is what is the case. So what happens is, in retinal surgery, you often use heavy fluids. You use PFC oil to reattach. And so if the retina just moves by a little bit, you have to think of the fact that wherever you're used to having your picture, the cells that are taking, the RPE and everything is moved by just a little bit, and it's like, wait a minute, everything is turned or everything is shifted by just a little bit. And so we see that right here. And right there. And that's called retinal displacement. Right. So retinal displacement is actually a common problem. In some cases, some studies have said up to 72%, which is kind of crazy because you're like, well, how many people, if it's 70, 3/4 almost, but it must be in a lot of cases so minimal that people don't notice it, or they're happy that they see anything, and so then it's like, but if you have these really, really, really great outcomes of like 20/20 vision or 20/30, and you're like, wow, we saved your eye, and they're like, yeah, you saved my eye, but what did you do with my eye? It's not the same. Then you have a lot of discussion. So it's something to discuss. honestly, if I say that right now, I'm like, I don't think I really do discuss it with them. Like, I always say, it's not going to be the same. And that maybe helps take care of a lot of things. Membranes, all the different problems that can happen. And people with a complete, total retinal detachment, they totally understand, because I mean they came in and it was completely dark, and now they see, even if they see 10%, they like, I see there is the door. But if you have the people coming in with 100%, with not 20/20, and then they're like, now the doors are like set over this way, or the people are smaller or something weird, then they're going to be unhappy. So, but that's why it's so important. And Mike, talk about what happens if we don't treat this disease. And if we don't treat this disease, you're going to go blind. And that's not even always the end. It's actually, you might lose your eye, because if you have an untreated retinal detachment over years, it's going to sometime involute, and it can really lose the complete globe. So, I mean, it's not like we have to tell a lot of patients that, but we do have our mountain villages where we have special people that have special, special relationship to reality, and then we have to talk about that. But I mean, if the patient doesn't want to be treated, it's okay. It's part of our job to respect the will of the patient naturally. So what can we do to prevent retinal displacement? And there's different studies out that have looked at that. There are lower rates with scleral buckling. I was just in a meeting in Berlin a couple days ago, and there was some older vitreoretinal surgeons, and they showed a bunch of cases that, well, I couldn't even do so in that way, because buckling is just something that is kind of it's kind of out of style in a lot of way. Because the one guy was saying, you have to bend over so much and it's bad for my back. You're like the surgeon, and different things. But so in a lot of cases, if you don't even have to use a tamponade, if you don't even have to even do a puncture and draw out the fluid, then you have way less, because you're not manipulating the retina. You're not moving it, and then that's one way. Then there's also pneumatic retinopathy and PPV with silicone oil. But the thing is, it sometimes even happens, even if you use the silicone oil, it can happen during the PFC exchange. Face down positioning is also a factor. And this is not in my slide because I don't have data, but it was just on this weekend I heard that one of the surgeons actually, for the first 2 hours, has the patient, no matter where they're going to position them later, because we were talking about positioning earlier, they basically put them facing, I would use so if you hang up laundry, you hang it up by the top and not the bottom, but it's sort of like you have the optic disc, the nerve, and you're using that as an anchor, so it hangs away from that. You see, so on the one side, you're always going to the temporal side, so that is an idea. You have to discuss with your hospital, because you definitely want the surgeon to decide what they're going to do, and if you're the surgeon, that's your choice. But that was an idea that the first time I heard, so that they do the first 2 hours, instead of first 2 hours face down, they can also do first 2 hours basically down to the temporal, laying on the temporal side, on the side. But I also have to say this is not something that was, there weren't any studies done about this, to my knowledge. This was just the idea of a veteran, surgeon who's definitely got good grasp on reality. Okay, so is time going too fast today? So we have the summary of retinal detachment. There's an increased burden. Good anatomical success after repair, good visual outcomes even with macula off, as we saw in some of the cases, and visual distortion is prevalent. So we have to address the theme, and we have to still figure out how we can minimize the numbers. Some take-home messages, and then we still can discuss. For regmatogenous detachments, we should treat all breaks, right? So what happens if you don't, for example, don't find all the breaks in your Goldman, mirror, or if you are not sure and you refer it to the surgeon? So it's important to pass that information on. Say, I'm not sure if I saw everything. Intraoperatively, every surgeon should check the periphery again and really make sure, because if you don't, you're going to get in trouble. Then we have the different techniques. So we have pneumatic retinopexy, which is more done in the States. We don't really do that alone, just putting air in and seeing what happens. I think that has to do sometimes with the way medicine works with, the patient comes back and then you do another surgery. See, maybe it helps, but you can bill every time, so you're like, I'm not saying it's a, go ahead. Yeah.
He's like the head of the people study. So one of my co-fellows from Spain works with him.
Yeah.
So what they do, you got a real attachment on a Friday afternoon.
Yeah, they'll just.
Then you will just do a pneumatic and see it during the weekend. And if it works, okay. If it doesn't work, they will do surgery.
Right. So that's a good point. So it is good for a Friday afternoon, Also, there's a lot of good things for Friday afternoon. Beer is good too, but air is also good. So yeah.
So I think that's why they do it. They have like the highest number of pneumatic per vaccine. I think SCAT, they're the
Right.
ones that are doing it.
Right.
And again about the displacement, he presented in the Retina last year.
Mm-hmm.
They have less displacement when you do pneumatic because supposedly the fluid comes out of the retina slowly, so that doesn't go that much displacement. I think it's that, the first one.
Right. So that's interesting because so it's a lot of the sudden changes. That's right. And that's the whole thing about scleral buckling is also you have a slow resorption of the fluid, and it can find its way back to where it used to be instead of being like you force it with for example, PFC oil or PFC fluid.
But yeah, we do in Mexico, we don't do pneumatics a lot.
Okay. Right. And so that's something that is like it's important. How do we teach surgeons? I think it's important, even if something is not used often, to have an arsenal of choices that you can use for surgery.
But I think for prevention, we can never tell. We can say that retrospectively we should have been done instead of buckling. But after when you have that, the reposition, displacement.
No, after that it doesn't help. No.
Yeah, how should you know if you do the scleral buckling or no, even if you
So that's a good question. So, for example, if you have a phakic eye, and you have high myopia or whatever, that you're like, wait a minute, I'm starting down the road. I have to do this eye, then I have to do the other eye because they're going to have isometropia, and then that's one reason. Then you have the position of the break. If you know it's in this place and this is the only break, it's another idea. If you can do it with one. If your access is there, you don't have to take away a muscle or so. That's another important factor. Right, and the reason is these studies are important because if you wait long enough, there will be not enough of this procedure to compare it with another procedure, and then you're down the road and you're like, we could have had these choices, but we don't really have them anymore because now can't compare them. Because if you start learning it, it's different than if you were doing it all the years. So it's kind of important that we don't lose some of the non-cool operations. And one thing is reimbursement. It is a problem. Guy says, well, look, oh, sure, I can treat the patient with the same outcome, but I get, I'm just going to say some number. I get, $500 for this, and I get $5,000 for this. Some people, they think with their important part of their body is back here, where the wallet is. I'm sorry, we don't think like that at all, but other people do. So we do have to, and then there is the aspect of, okay, it takes me an hour this way, it takes me an hour this way. I have to pay for my employees. It's not just about getting rich, it's also about so sometimes it's reimbursement. I'm like, why do they not treat the outcome? Say, okay, this is, no matter how you get to this outcome, you're doing the patient a favor and the system a favor. If a patient is a happy outcome, can drive again, can work again, then it doesn't matter if you do some expensive thing or something cheap. You got but that's a whole different thing. That's health economics. Any other questions for that? So, right. Oh, then we have tractional detachments. I didn't have any example of those, but like in a case of diabetes, we have to really relieve all the tractional elements, be it epiretinal membranes or subretinal membranes. In PVR, PVR is the main cause of repair failure, and there are reasons for that. What is one of the reasons for PVR? Extremely important is to really get rid of as much of the vitreous as you can. So it's also, again, a tedious part of the job. It's like shaving the whole vitreous down. Second thing is excessive laser can be a problem. So if you have the laser power up too high, it can actually make RPE cells kind of migrate into the cavity. Then another reason is naturally delayed operation and reoperation. So the problem is, do I want to choose an operation technique that really fixes it and fixing it for good? Naturally, I do want to, but sometimes it's the case that the success rate is 90%, so 10% have to be reoperated, and then you have the second surgery, the third surgery, and so on. And rhegmatogenous retinal detachment is most often confused with retinoschisis and serous retinal detachment. What is the difference in treatment if you have serous retinal detachment? Not primary, yeah. First you have to figure out why does the patient have this. And so it's more a diagnostic road you have to go down to figure out if there's a tumor or some, infection and so on, inflammation.